Good morning. My name is Regina Fink, and I'm an associate professor at the College of Nursing at the University of Colorado in Denver, and the School of Medicine associate professor as well. I'm here today to talk to two experts about compassionate extubation. On our left is Barbara Wanger. She is the Oncology and Bone Marrow Transplant Clinical Nurse Specialist at the University of Colorado Hospital. And on our right is Harry Brackett, who is the lead clinical nurse specialist on the palliative care team at the University of Colorado Hospital. They have been integral in developing a compassionate extubation program here at the University of Colorado Hospital, and I'd like to interview them today, talk a little bit about that project. So first I'd like to ask both of you, tell me, what was the impetus for starting and developing a compassionate extubation protocol here at the hospital?
You know, a couple things. Our palliative care team has done several compassionate extubations in the ICU, and our medical director kind of ran into this really amazing video of this young woman named Bara, who had MS, and she had many complications from MS, and she was on a ventilator, and this was at a hospital in a community hospital in southwestern United States, where her parents really wanted her to feel the sun on her skin because they knew that they had to transition her to end-of-life care because she wouldn't want to be on a ventilator anymore. And continuing aggressive medical care was just really not in her goals. So this community hospital actually was able to move her bed and move the ventilator outside and be able to compassionately extubate her outside. And we thought, well, you know, certainly we can work on something like this here and maybe do little steps. So we opened up 4 palliative care rooms at University of Colorado Hospital, UCH, and we thought, you know, that could be the setting to do our compassionate extubation and move people out of the ICU to a quieter environment, maybe more home-like, and with nurses taking care of them who've had specialized training in end-of-life.
So I know you didn't develop this protocol in isolation. You involved an interdisciplinary team. Tell us a little bit about who's on your team, who helped you to develop this protocol and who you involved.
Okay. Actually, it was the palliative care team that led the discussion on this as far as how we wanted to do this and what the plan was. Met with the leadership group up here. On the 11th floor, this is the unit that does have the 4 floating inpatient palliative care beds, to see if it was a process that we could perform up here. So we got the approval from the leadership on this team, and then it went to how could we put this together, and we actually partnered with the Wells Center, which is, I forgot now. Sorry, I'm trying to remember what their acronym is. It is Work Education Lifelong Learning Simulation Center. And they were actually a very integral part as far as helping us plan more an organizational process of how to move forward to do this type of a procedure, and then from that procedure build it into a policy.
And we can't forget that we couldn't have done this without ICU leadership. So the ICU nurse managers, nurse educators, nurse specialists, and also respiratory therapy, because
Great.
they play a part in discontinuing the ventilator.
Right.
So why don't you tell us a little bit about what's included in this protocol?
Okay. So UCH had developed comfort care orders for the ICU many, many years ago. So we already had those comfort care orders, and we already had orders and guidelines in place for compassionate extubation in the ICU. So we didn't have to start from scratch. Then we added many parts. There are many moving parts as far as how to actually transport the patient from the ICU to the 11th floor palliative care bed. And all those moving parts are actually included now in the protocol. And it's interestingly enough, we had to meet so many times because so many things were missing, and so many worries and problems came up, because you would think that moving a patient from ICU to 11th floor to a med-surg bed wouldn't be that difficult, but you have to think about, well, the transport ventilator and the oxygen on the 11th floor, will it hook up to the transport ventilator? And the ICU bed and the 11th floor bed. Moving the 11th floor bed up to ICU and transferring the patient onto that bed the night before. And then you have to think about, is a room going to be available? And then you have to think about the comfort level of the med-surg nurse. A lot of them, most of them, were freaked out about actually being involved in extubation because they've never done this before. Their specialty is oncology. They have a lot of end-of-life training, but actually taking care of a patient who's being extubated was way out of their comfort zones. So the experts were the ICU nurses.
Right.
Well, we had to work on taking these ICU nurse away from that unit and transferring her with the patient to the 11th floor for plus or minus 30 minutes.
Right.
30 minutes to an hour. Well, that left a gap in their staffing in ICU. So there was a lot of negotiation.
I think a lot of it too with the med-surg nurses, when they first mentioned this topic, our big fear was, wait a minute, I don't know vents, I don't know how to extubate a patient, and I think we brought the fear level down tremendously by saying that's not the part you're going to be doing. We're leaving that to the experts, the ICU and the respiratory therapist, and when we got the impression, or got the procedure to them as far as you are not extubating, you will get the patient once they've been extubated, and then this is the same end-of-life patient you have been taking care of for years here now. Once we got that part discussed, or not discussed, I don't know what the word I want, but once we got that point across, most of them, the anxiety level did go down of, okay, so I will not be dealing anyway with the vent other than being back there for support for the ICU nurse if they need particular meds.
So generally the palliative care team is with that patient the entire time.
Mm-hmm.
Okay.
And we're with that patient the entire time if they're being extubated in the ICU or extubated up here. So that was one way to alleviate that fear.
Right.
The other way is to have them realize that RT, respiratory therapy, actually does the task
Right.
and the procedure of suctioning the patient and removing the tape and actually pulling the ET tube. Their job is to make sure that the patient's properly medicated pre-bolus and after the tube is gone. And that's something that they've already been doing.
So you developed a novel approach in educating staff about how to do this, and tell us a little bit about that novel approach, simulation.
For the simulation piece.
Yes.
That was actually quite a few planning sessions, I think, with the palliative care group, with the myself, the clinical nurse specialist, Shannon from the intensive care units. It took a lot of planning in that room, but the planning in the room didn't actually show us what was actually happening until we got the opportunity to do the simulations. And I think you mentioned something about, we had 3 simulations in June, July, and August. They were one-day simulations that we had a lot of support from the hospital as far as this, because they actually blocked off rooms for us. Our biggest plan for doing this was we did not want to do it over in the simulation center, just because we didn't think we could get as much of the equipment the same, and we wanted to know that traveling pattern from the ICU to the med-surg area. And the only way you could do that is to do it in the actual atmosphere. So we did do it with with a real ICU bed here, transferring through our hallways and bringing to a med-surg unit. And we had a lot of support from the upper management of blocking those rooms, so that we had I think it was a 4-hour simulation on each of those days where they came over early, they set up everything to make it look as real as possible, and then we brought in some charge nurses from the med-surg area and ICU charge nurses, and Shannon also participated as one of the charge nurses with the ICU team. Respiratory therapy was part of it, and the palliative care team, so that we actually did a simulation with one of their mannequins from the Wells Center, where they brought everything over here and we went through the process step by step. Which the biggest piece I think with that was what Harry mentioned, brought up our issues of, hey, the bed does not work from ICU to our floor. We need a different connection. The equipment is not the same. They use drips upstairs. We can't use drips on the med-surg unit, so we're going to have to flip over to PCAs by the time they come to the med-surg unit. So it brought in a lot of those little things that we wouldn't have thought of in that planning room.
Yeah, it smoothed the glitches. Another important element was just the personal aspect of it.
Right.
You know, the nurses in ICU, they become very close to their patients. And leaving their patients and just giving their patient to a total stranger, the oncology nurse, and these patients and families being adapted and accepted by a total stranger, they felt was a little bit cold. So because of this simulation, we came up with the fact that we had to do a pre-meet before it happened. So part of the protocol is that when a compassionate extubation is being arranged, part of it is a pre-meet. So the nurse from 11th floor goes down to the ICU, and the ICU nurse actually introduces them to the family. And this is the person that will be, I'll be handing off care to this person.
And that was another person in the simulation that did give the aspect from the family, because they did have one of the members from the Wells team did come over here and did act as the actor with as a family member, so that they could see it from that point of view too, and tell us how did that feel for the family member as far as knowing the staff. And that was one of the points that they did bring up, that it did feel like, who are these people that are coming into this room and now you're just turning it over to them? Who are they? So that pre-meet did make a big difference with that.
So all of the oncology nurses are pretty much educated on this process, or is it just a specific group of nurses, and do you think they're ready to do this?
They have been shown, there are quite a few oncology nurses. I think we mentioned the word ELNEC, the End-of-Life Nursing Education course, has been a prerequisite up here for this group, and we have quite a few nurses that have taken that course, so they know quite a bit about end-of-life. And with this type of population up here, it isn't something that's unusual for them to take care of these type of patients. They did get that type of training. They know the procedure as far as what is happening up here, that we gave the general information. All of the charge nurses know a little bit more, I think, as far as with the training than what we did with the rest of the staff. Since this is something that is pre-planned, it will not be something that today at 2 o'clock we will be doing this and bringing this patient up here. It will be more of the palliative care team coming to us today and saying tomorrow morning at 11 a.m. we're going to transfer the patient up here and do a compassionate extubation, which allows us a little bit more time to meet with that care team member that is going to be doing this and prepping a little bit more of, okay, here is what's going to be happening. Plus the fact that there is a detailed policy with checklists on the policy telling them this is the step-by-step of what you're going to be doing for this. So the main education has been out there, and then when this does occur up here on the floor, we will be able to do better one-to-one training with them to know what's coming up.
So where do you go from here? How are you planning to evaluate this compassionate extubation process?
So we've developed surveys to give to the family members, and they will be emailed or through one of those Zoomerang.
Right.
And to the family members and to the staff involved.
So what would you tell other nurses who maybe are viewing this video who are thinking about doing something like this in their particular organizations or institutions. What would they need to do to develop this? Is this something you're going to be publishing? And have you looked at any particular evidence that informed your protocol?
So what would we tell other people? I think we would tell them that you need a significant amount of buy-in, and you need a significant amount of support from administration and from different areas in your hospital. Not only palliative care, but the actual med-surg unit that you might be interested in involving, and especially ICU and respiratory therapy.
Yeah, as far as the prep for that piece.
Any
Yes.
particular evidence that you reviewed that informed this protocol that comes to mind?
So, we just completed updating the end-of-life policy. And the evidence that we looked at is throughout Center to Advance Palliative Care, CAPC, the NCP, National Consensus Project, the Institute of Medicine recommendations, and
A lot of the symptom control and
symptom control.
came from Farrell and Coyle with their Oxford Palliative Care book, the newest edition with it.
Okay, great. Well, I really appreciate you taking time from your busy schedules to participate in this video, and I know that the nurses who view this will be very excited to hear about this, and you may be receiving some emails about this if people are interested in picking your brain about how to do this in their particular settings. Thanks for your time, Barb and Harry. Really appreciate it. Take care.
Thanks.
Thank you.